Welcome to Let's Talk Patient Blood Management. I'm Sarah, and I'm here today with my co-host, Chris Ting. Today we're joined by Katherine DiPalo, a clinical pharmacist with deep expertise in geriatrics and heart failure.
In this episode, we'll unpack why iron deficiency is so often missed in heart failure patients, the difference between IV and oral iron, what to ask your doctor, and how pharmacists like Dr. DiPalo are changing the way we think about treatment.
You have a doctorate in pharmacy medicine. How is that different than any other medical degree or pharmacist?
No, so the Pharm.D or doctor in pharmacy degree is now the standard for pharmacists. And what really is, I think, the differentiating is the training you do after. So with Pharm.D, you can then do postgraduate residencies. We call them PGY1s, and just it could be 1 year or 2 year. And after you do a residency, you become eligible for board certification. And that's where you can really specialize. So my specialty is both geriatrics and ambulatory care.
Okay. So it's a medical expertise, but you are not a medical doctor, right? Can you tell
I
me the
am
difference
not.
between the training for a medical doctor and a pharmacist?
We both go to undergrad, 4 years. Sometimes there's pharmacy schools where you can do 2 years. But after those 4 years, the branch goes to medical school, which is another 4 years, or to pharmacy school, which is 4 years. I think nowadays many pharmacists and doctors are both graduating with 8 years of schooling, the last 4 being specific to medicine or specific to pharmacy. And then from there, they'll go on and do additional residencies and or fellowships.
And what made you interested in going the pharmaceutical route? Tell us a little bit about your story.
My first job in high school at 14 years old was at the lottery counter of a community pharmacy. It was one of those community pharmacies that had a Hallmark gift shop attached to it. The trajectory for high school students, if you were good at the lotto counter and trustworthy, and back in those days, you knew how to give change with a cash register, not a calculator. But if you could count change, then you moved up to the prestigious gift shop and you could wrap presents. And if you were really dependable and didn't call out sick, you could count pills in the back. I was very aspirational and I was like, I want to get to the back where, the real responsibility was. And I very quickly saw how patients would come in and they had just so much trust with their pharmacist. They knew their pharmacist by name. Their pharmacist knew them by name. They knew their families. And they would be that partner in the community that was really putting the patient's health together. I was really fascinated by that. I felt like the medications were so critical and it was something that you could see the difference that it would make, again, not only for the one patient who's going in, but really on the family and on a generational level.
Wow, that's a great story.
Right. Yeah.
What is one thing that you wish everyone knew about a pharmacist?
So we unfortunately are not recognized by the Centers for Medicare and Medicaid, or CMS, as healthcare providers, which I think is remarkable
Wow.
because we absolutely provide care to patients and we do it very differently than doctors and nurses. And there's room for all members in the healthcare team to provide care. The recognition of provider status would allow pharmacists to bill for their services. Usually when I talk to my colleagues at other health systems, that's the rate limiting step. We recognize the value of a pharmacist. We would love to have you on a team. Unfortunately, you do this pro bono because we can't bill insurance and we can't have that type of reimbursement for checking medications, optimizing therapy, ensuring that we prescribe iron to patients with iron deficiency and that it's affordable, covered by their insurance, and that patients understand how to take their medications. When you see a pharmacist in clinic, it's usually the health system or the clinic that said, you know what, even if they can't bill, there's going to be value in this for our patients.
Wow.
What's the difference between the way a pharmacist operates in the hospital versus like at CVS or at a counter?
It'll depend where you are in which community pharmacy or
Hmm.
which hospital. So I like to think of it as no matter what type of pharmacy setting, somebody is always checking to make sure your drugs are dispensed correctly and that the drugs that we're providing don't have interactions with things that you're already taking, that they're safe. And that's going to be the same hospital, community, even in long term care settings, nursing homes. The next kind of layer of that is the clinical services they provide. So in the hospital, you may have pharmacists that are rounding in the cardiology care units or the ICUs, and they're working with the physicians and the residents and PAs to help that with that optimization, where it's not only this is the drug class we need to do, but this particular drug, ferric carboxymaltose versus iron sucrose, this one's better than that one for this particular patient. Even on the community side, we're seeing more and more active role in ambulatory care when it comes to chronic disease management. And that's my area of specialization. It's once that diagnosis is made, you have heart failure. The goal is to get you on 4 evidence-based medications, but it's not a one size fits all. Within those 4 classes, there's 3 different beta blockers or there's 4 different ACE inhibitors, which is going to be the right one for that particular patient. That's where we really can specialize and we have the time to try different approaches. Of course, once we get the right drugs on board, it's ensuring our patients can afford and continue to take them.
What made you want to specialize in geriatrics and in heart failure?
I was lucky enough very early on in my career to have one of the most incredible mentors and physician champions, Dr. Ileana Pina, who is just a pioneer in the heart failure space. Came from the Department of Veterans Affairs, which is also where I did my training. She was at the VA in Cleveland. I was at the VA in the Bronx. The
Mhm.
VA model is very unique in that pharmacists are recognized by providers and would be integral to the team. We would have kind of pods of practices where you'd have the doctor, nurse, and pharmacist, and we'd all be working alongside each other and really leveraging our areas of expertise to come together and make life easy for our patients so they wouldn't have to go here, there, and everywhere. That level of team-based care is, I think, so critical and unfortunately in our current reimbursement schema, not reimbursable.
Mhm.
When I came over to more of the academic healthcare, health system side, to have a physician who was looking for a heart failure pharmacist to implement a team-based model, we were speaking the same language. We could complete each other's sentences from day one because that's where we trained. And we had that shared mission and vision, which was always patient-centered. I have been lucky for over the last 10 years to have such an amazing mentor. I'm very excited. I'm going to see her at a conference next week and we're going out to dinner to catch up.
Awesome.
Great. Yeah.
Awesome.
I saw that you went to University of Buffalo. I'm a Rochester girl, so
Oh, yeah. Western New York. Go
that's
Bills.
right.
Right?
Yep.
What's heart failure? How would you explain it to a person that, doesn't have a degree, a medical degree or a farm degree?
It's a tough one. It's a
Hmm.
really challenging name because when we think heart failure, especially if you're a patient, the word failure has such a negative connotation. If you're a clinician, you often don't say that word failure. You'll
Hmm.
say there's a problem with your heart. Your heart is weak, which then makes patients think I've got a condition where it's not as serious as it is. But heart failure is a progressive chronic syndrome that is resulting from some type of injury to the heart. That can be a heart attack where your heart becomes weak and ineffective in its ability to pump. It could be 20 years of having high blood pressure. That's caused some structural changes to your heart. It could be due to a leaky valve. that is now causing your heart to work harder. So there's many different ways you can get to this kind of overall outcome of having a weak heart that, depending on, the type, you have different evidence-based medications that can help improve. Our goal really with heart failure, with the medications that we know improve what we call morbidity and mortality, basically adds years to your life and makes you feel better. With those medications, we can actually recover that heart failure and recover heart function. That's our ultimate goal. So this is something that I think my team struggles with. And it's like, I'm sometimes the first person who's used the word heart failure in talking to my patients because we dance around it. It's scary from a patient perspective, but when you have the luxury of time and you have the ability to really explain what it is, what the trajectory is, and what our goals are, and that's recovery, it becomes a little less daunting of a diagnosis.
Mm-hmm. Sure. Do you find that using that word heart failure helps people to be a little bit more serious or take their health a little bit more seriously? Or
Yeah,
mm-hmm.
we have to call it what it is until we have
Mm-hmm.
another name for it.
Mm-hmm.
In the heart failure community, there's been, petitions to
Mm-hmm.
change it, but we have to call it heart failure. But we have to have that little asterisk of, just because the, disease is called heart failure does not mean there's nothing we can do to make you better.
Right.
With the lifestyle modifications, with really good self-care, with having the right medications, with devices, with procedures. Our goal is recovery, and it's not a end stage failure. That, I think, is what patients hear when they hear failure, like this is the end. It also kind of ties in, we talk a lot about kidney failure. A lot of patients know what happened with kidney failure, right? That's like dialysis. That is
Right.
pretty severe. So I think that connotation with failure really scares patients. So it needs to come with that asterisk of, what does failure mean and what are our goals?
What is their quality of life? What are the challenges that they have? What are the symptoms?
Our symptoms are very similar to those of iron deficiency, which is shortness of breath, fatigue, swelling, which can be edema of the legs. It can be swelling of the gut. It's fluid accumulation around the lungs, around the heart. It's a decrease in your tolerance to exercise or to even walk. All of those things contribute to very poor quality of life, a high symptom burden. We also see very high levels of depression, anxiety, insomnia, which often go undiagnosed or treated and creates this kind of vicious cycle. The good news, though, is with, of course, medications, with self-care, which includes monitoring your weight, watching your diet, ensuring that we avoid salt. We say simply, don't add salt, leave the salt shaker off the table so that you don't get that fluid accumulation, which would worsen your symptoms. It's very manageable with self-care.
Mm-hmm. You brought up the iron deficiency. Is that common in heart failure? And is that sometimes glossed over because they attribute those symptoms to heart failure and maybe don't think about the iron deficiency?
Absolutely. The prevalence of iron deficiency in patients with chronic stable heart failure is around 50%. So that's 1 out of 2 patients.
A lot.
And that can be with or without anemia. A lot of times we think, okay, I need that hemoglobin, that my patients need to be anemic for me to start doing this workup to see what's causing it. But we see iron deficiency, again, with and without anemia. And in our patients who are hospitalized, the prevalence increases. It's almost up to 80%. So it's very common. Those overlapping symptoms of shortness of breath and fatigue, is it the iron deficiency that's causing it? Or is it the heart failure? Or is it both of them together that's making you feel additively worse?
What does iron do for the heart?
Why do we need iron? Well, we need to make energy and we need to carry oxygen. And our heart's a muscle. Just like any muscle, the iron is going to help it work effectively. It's going to help the cells in the heart make energy. The heart never takes a day off. It's constantly working. So when you are iron deficient, your body, your heart, it's not going to be able to produce enough energy. not enough energy. That's like getting a bad night's sleep, right? You're tired. You're going to have symptoms of fatigue, and it's going to really be challenging. That again will contribute into your heart working even harder. When your heart's working harder, that's heart failure as well. It's a vicious, vicious loop when it comes to iron deficiency and heart failure.
Do you prescribe oral iron to all of your patients that have heart failure?
This is where it gets tricky. I'm going to explain some of the mediators of why we won't go into oral iron, but then also just break it down simply. What's also happening here is that we have this chronic inflammatory state in heart failure. With that state, we're triggering a hormone called hepcidin to be produced. Hepcidin will end up blocking your body from absorbing iron into the gut, into the stomach, and from using the iron that you already have. We also have this other type of moderator called ferroportin. We can think about this as the protein that's going to allow the iron that's in the cells to get into the blood. It's the gatekeeper. Unfortunately, hepcidin is telling when we have too much hepcidin in that chronic inflammation, it's really degrading ferroportin and it's shutting the gate down. You might even have iron in your stores, but it's not getting to where it needs to go. If we are having that type of absorption issue where we can't get iron in the gut, we really don't want to give oral iron. If we did, it's going to take a very, very long time for it to work. When we go to our pharmacies and we say, oh, it's iron 325 milligrams, we're not actually getting that 325 milligrams. We have to go down to how much elemental iron there is. And because we're not getting as much, it's going to take way longer. It's going to take longer to absorb because of that hepcidin. There's just also poor bioavailability and side effects that sometimes even prohibit our patients from taking it. Some of our oral iron preparations have got to be 3 times a day. I struggle to take my once a day morning medication.
I know.
So having a every 8 hours or 3 times a day can be really daunting. On a good day, if we went down the oral iron route, 6 months, sometimes 12 months to get repletion of your iron stores by a pill.
So you do IV iron then?
IV iron. So here's the difference. When you take a pill with oral iron, you're getting 10%. IV, we don't have any of those issues in terms of the absorption. 100% of the drug is available. We can get to our target dose, 1,000 milligrams. We can get there quite quickly. So it's not going to be months. It's going to be 1 or 2 doses.
There are some people that have some fear of IV iron because I know in the past there have been some formulations that cause some side effects, and even the current formulations, any medication you can have side effects. Can you explain a little bit about like what the newer formulations are and how they aren't quite as dangerous as some of the older formulations?
Yeah, there's absolutely reason to be concerned. This is one of the ones that still makes the headline. When you Google, sometimes you're going to see very scary things about IV iron. And that goes back to, the original drugs that came out in like the 70s and 80s, having some very serious reactions relating to them. What we have now seen is these next generation formulas that have gotten incredibly safe to take, that have very few side effects, and that we, of course, monitor for. With our newer formulations, ferric carboxymaltose or ferric deoxymaltose, what's really different here is it's the sugar shell, and different sugar shells allow different amounts of iron to be released. If you have certain shells like these carboxymaltose and the deoxymaltose, it just means we can give you a higher dose and it doesn't take as long. It could be 15, 20 minutes of an IV versus an hour. The typical side effects that we might see are nausea, can be some flushing, and they can just be related to the rate of the infusion. If you have a side effect with one iron product, there's a couple different ways that we can mitigate that. I think that's where the care team decision and the shared decision making with the patient is so critical in terms of if you've had a bad reaction with one, what are the options for making sure it doesn't happen again or trying a different product?
Wow, Mary
Yep.
Poppins knew what she was talking about when she said just a spoonful of sugar makes the medicine go down.
Yes.
Obviously, all patients want the best medication, they want the best treatment, but sometimes costs can be prohibitive. Is there like is it a huge cost to this? Are insurance companies covering this? I know sometimes that can be difficult sometimes.
Yeah, these are tricky to navigate. This is not a medication that you can go to your community pharmacy
Mhm.
and pick up from, behind the counter. These are typically infusion center drugs that are going to either be part of a hospital clinic or another, like an infusion center. The good thing here is that the infusion centers are usually pretty savvy on how to get it and how to navigate the insurance side of it because one formula will be covered. That's the good news is that
Yeah.
the payers will cover one. Is it going to be the one that you can get the one-time dose of 1,000 milligrams, or is it going to be the one that is 200 milligrams and you need to make 5 trips to do
Mhm.
it? That's the, I think, key in terms of talking to your care team, talking to your insurance company as well.
Yeah.
I always empower our patients to pick up the phone and call, ask, what is on the formulary? If you hear something like, well, we only cover the one that is 5 doses, alert your team because sometimes they can do an appeal. Sometimes where I practice in the Bronx, we got a lot of traffic. It's challenging to get in. It requires, transportation, caregivers. It's a lot to, move around your life to get 5 different appointments for your iron. So we might call your insurance company and say, we know you prefer this one because it's cheaper, but for our patients, the one that's a total dose is going to set them up for success because it's going to be really tough for them to get in 5 different
Yeah.
trips, or they don't have the support to get in 5 different trips, or they live an hour from the infusion center. And those are the ways that your care team can really advocate on your behalf.
Right. I think that's a great point. I think they just assume once my insurance company says no, that's no. I think it's really important that people know that these things can be appealed. This is a good way of helping the insurance companies to change too, because if they're getting a lot of appeals, they may
Yeah.
reconsider some of the things that they're denying in the future. So I think that's really important.
That is a great point. You said with oral iron, it could take 6 months, maybe a year, just because of poor absorption and inflammation that kind of hinders all of that. IV iron, much faster, maybe a month. Can you give us a real life example of how you have seen someone's quality of life change because of just addressing iron deficiency?
All right. I'm going to tell you my favorite story. We had a patient who had heart failure and always was experiencing shortness of breath. When you can't breathe, it's quite reasonable to call 911. Like that
Yeah.
is, in my mind, can
It's
be a
frightening.
medical emergency. That's scary. I can't
Yeah.
breathe. Used the emergency department, was hospitalized more times than you could count on 2 hands. And during one of her hospitalizations, we started to treat her iron deficiency and she felt better. Now, this was the scenario where we didn't get to give the 1 dose, but we gave 3 and she got up to 600 milligrams. Her insurance company actually called us because they had her kind of flagged on their radar as
Yeah.
somebody who was constantly using the hospital, which we all know is the most expensive place to get your health care. They said when we spoke to her, she told us that she felt better after you guys gave her IV iron. Can you make sure the next time she's hospitalized, you finish the job and you replete her iron, or let us know what we need to do to have her get her iron repleted as an outpatient? I know sometimes people are skeptical, like the insurance company is there to, block and prevent everything from happening. But
Right.
this was the first time an insurance company called us to say, thank you for taking care of our patient. They felt better. what can we do to make sure that they continue to feel better?
That is great.
Are there places that patients can go to learn a little bit more about IV iron, anemia, any of these things? Do you have any like good resources that we can make sure that our viewers have access to?
Yes, I will give a shout out to the Society for the Advancement of Patient Blood Management, or SABM. That's one of our professional societies. They have a fantastic section of their website that is called the Iron Corner. There are references in terms of the evidence. There's information on the
Awesome.
different products, the different kind of disease states that iron deficiency, and especially repleting iron, is important, because it's not just heart failure, it's kidney disease. There's a number of comorbidities that we really want to pay attention to. Check out the Iron Corner on the SABM website.
All right, we'll make sure
Yeah.
to post a link in the bottom of our description so that you'll have easy access and can just click on that if you want some more information about iron replenishment.
My takeaway is that pharmacists are part of the superhero team. Everyone thinks about the doctors and the nurses, but the pharmacist is really another piece of that team and another resource that probably goes untapped by clinicians, but also by patients too. I think it's really great that you came here and explained some of these things, because each part of the team has a different perspective and a different level of education and a different area of expertise. Really, when you combine those two together, or those three or several team members together, however many people are on the team, you're really going to get like the full spectrum. I think it's really great, and I appreciate, that you came here and talked about this. Do you have any takeaways that you'd like to give a shout out for yourself and brag on yourself a little? I mean, this is your time.
Well, I just say thank you, Christine. Thank you, Sarah, for having me. We use the phrase in heart failure, like, it takes a village, because we need as big of a team as we can have. We include patients, caregivers, family members, all as part of that team. I'll say in 2025, I've been in heart failure for well over 10 years. There's never been more medications, devices, therapies, and the future is very bright in terms of treating heart failure. If you have heart failure, that F word, failure, is scary, but there's a lot of hope. There's a lot of evidence and science that will improve your outcomes, improve your quality of life, and of course, add years to your life.
Thank you
Great.
so much. Great
Thank you.
conversation.
This conversation helped you better understand heart failure, iron deficiency, or the critical role that pharmacists play in patient care. Go ahead and hit that like button and subscribe to the channel.